Hello everyone, hope you are all doing good. In this video, we are going to discuss about premature rupture of membranes. It is PROM. So, if you see labor, normally how it should proceed is that first the uterine contractions will happen and this will lead to cervical effacement and a full dilatation. Okay. That will be around 10 centimeters and then the membranes will break down, letting out the amniotic fluid, and then the fetus will be delivered. Clear? So, this is the ideal sequence, a rough sequence of how the labor will be proceeding. Okay. So, due to any cause, if there is rupture of the membranes before the onset of labor, then it is known as premature rupture of membranes. Okay. And especially when it happens before 37 weeks of gestation, it is known as PPROM, that is preterm then premature rupture of membranes. Clear? Right. Now, we will see what are the risk factors for PROM. So, risk factors include for the mother as well as for the neonate. Okay. So, first we will see what are the risk factors for the mother. First one, there is a chance of infection, chorioamnitis, intraamniotic infection, then that can result in sepsis. There can be puerperal endometritis, and because of this there can be associated risk of retained placentae. And in the neonates, there are increased chance of intraventricular hemorrhage that can result in cerebral palsy. There are chances of pulmonary hypoplasia, and when this happens in a much early gestational age like less than 24 weeks and all, there are chances of even limb deformities. So, we will see what are the clinical features now. Okay. So, clinical features include symptoms like the patient may complain of a sudden gush of fluid from the vagina. There can be fever or foul smelling discharge, and there can be abdominal pain also. Okay. So, that means these are mostly linked with chorioamnitis. Clear? Okay. And the next one, we have to see the examination findings. Okay. So, during examination, you have per speculum findings which include, you will be able to see a vaginal pooling of amniotic fluid. And remember, in this case, you should avoid per vaginal examination. Okay. A digital finger examination per vaginally has to be avoided because this is associated with increased risk of infection. Okay. And what you can do is, you can take a slide of this pooling, whatever secretion or fluid, whatever it is, we have to differentiate it between the vaginal secretion as well as amniotic fluid, because excess vaginal secretion during pregnancy is also a normal physiological change we see. So, what you have to do is, you have to take that secretion and you have to slide it on a glass slide, and you will be able to see ferning in case of amniotic fluid. Okay. And you can go for nitrazine paper test. So, Nitrazine paper test, when you do, if it turns blue, okay, then it indicates PROM, because mostly amniotic fluid is going to have a alkaline pH, right. Suppose if it is going to turn yellow, then this is going to be the vaginal secretions, okay, because vaginal secretions are normally acidic and the acidity is more increased during pregnancy. Clear? Yes. Now, sometimes with this test, there are chances of false positive results, and the conditions which can cause false positive results include the presence of blood, semen, or if there is urine contamination, or there is a bacterial vaginosis. False negative result is also possible. False negative result is seen in when there is scanty amniotic fluid. Clear? Apart from this, some of the bedside tests for detection of insulin-like growth factor binding protein 1 and placental alpha macroglobulin 1 is also available. Okay, but these are expensive, so they are not used routinely. You can do a ultrasonogram which will show features of oligohydramnios, and another test using ultrasonogram you can do is you can install a dye, namely indigo carbon dye, using ultrasound guided amniocentesis, and the appearance of blue dye on the vaginal tampon is checked. So, that means there is rupture of membranes. Clear? Yes. Now, how we are going to manage this kind of complication? So, management usually depends upon the gestational age. So, you have to check the gestational age first. If the gestational age is more than 37 weeks, you have to consider prophylaxis for group B streptococcus. You have to give antibiotics for chorioamnionitis, and you can deliver the patient by induction of labor. Otherwise, cesarean section is indicated only for obstetric indications. Okay? Then, if the patient is between 34 to 34 plus 6 weeks, then you can plan expectant management. We have to allow time for the term cutoff, okay, up to 34 plus 6 gestation means you have to give expectant management. Then delivery can be planned either by induction of labor or cesarean section, and during this period you have to plan to give corticosteroids if the delivery will not happen in another 24 hours to 7 days at least. Okay, you have to do GBS screening as well as prophylaxis, and you have to give antibiotics for chorioamnionitis. Yes? Now, what will you do if the rupture of membranes happens much earlier? Like if it is happening before 24 weeks to 33 plus 6 weeks. Here also you can plan expectant management. Give corticosteroids, give antibiotics. Then you have to give GBS screening and prophylaxis. And if the labor is happening, if the rupture of membranes repeating, and suppose if the rupture of membranes has happened less than 32 weeks, then you have to consider neuroprotection with MACSILF. Okay. So, in case if suppose there is associated chorea amniotic, then you are not going to give corticosteroids. Clear? Yes. Now, what will we do in expectant management? See, when the rupture of membranes happens, most of the women deliver in the following week. Okay. So, that means within 1 week mostly delivery will be over. Okay. Suppose if there is a chance of expectant management, you have to proceed like you have to advise them bed rest, then monitoring of vitals is very important because of the associated risk of chorea amniotic, and at least thrice daily this should be monitored. You have to give antibiotics. Antibiotics that you can give include IV ampicillin and erythromycin for 48 hours, and after this it can be changed to oral amoxicillin and erythromycin for 5 days. And remember, erythromycin is the preferred antibiotic that has to be given in PPROM. Okay. So, erythromycin is the preferred antibiotic in preterm premature rupture of membranes. Clear? Yes. Now, I want to discuss about group B streptococcus infection. So, group B streptococcus. Group B streptococcus is nothing but Streptococcus agalactiae, which is a gram-positive organism. See, this infection has to be suspected when you have maternal fever, temperature is more than 100.4 degree Fahrenheit or 36 degrees Celsius, and there is a history of prolonged rupture of membranes, that is, it has taken more than 18 hours, and there is a risk of preterm labor, that is preterm premature rupture of membranes, when it is happening before 37 weeks. Okay. So, in this case what you have to do is you have to take rectovaginal swab for screening of group B streptococcus, but sometimes even this rectovaginal swab can be negative. Okay. So, what you have to do is you have to check for positive group B streptococcus infection in the urine. okay, because even in the absence of the rectovaginal swab positivity, the urine may show positive for heavy colonization of GBS, okay. So, that is why asymptomatic bacteriuria screening is also necessary, and if the GBS screening is negative also, between 35 to 37 weeks, you have to give antibiotic prophylaxis. Clear? Yes, we will pass on to the next one. So, what is the drugs? Repeating. So, what are the drugs we use for prophylaxis? So, for prophylaxis, the ideal drug of choice is IV penicillin G. Okay. So, this can be given at a dose of 5 milliunits as a loading dose, that can be followed by 2.5 to 3 milliunits every 4th hourly till delivery. Suppose if penicillin G is not available, then we can choose ampicillin 2 gram IV loading dose, and this can be followed by 1 gram IV every 4th hourly till delivery. Clear? Right. Suppose if the woman is allergic to penicillin, then you have to choose to give clindamycin, and dose of clindamycin is 900 milligram IV every 8th hourly till delivery. Suppose after giving clindamycin, if there is a resistance, then you can give vancomycin 1 gram IV every 12th hourly. Okay? And sometimes you can even prefer to give cefazolin at a loading dose of 2 gram IV, that can be followed by 1 gram every Q8th hourly. Okay? And remember, most of these antibiotic prophylaxis are given during labor. Clear? Yes. So, we will see about intraamniotic infection now. Okay? So, what happens in chorioamnionitis? That is the thing, intraamniotic infection. See, this is a polymicrobial infection that is involving the fetal membranes, namely chorion, amnion, and also this can spread to the amniotic fluid, placenta. There can be isolated presentation or it can be combined also. Okay, so isolated presentation of the membranes, amniotic fluid or placenta, or it can be a combination of all these things also. And this will increase the risk of obstetric complications as well as fetal and even after birth the neonatal complications also. Okay. So, what are the risk factors for getting chorioamnionitis? Risk factors include rupture of membranes, that is premature rupture of membranes that has been taking place for a long time, for more than 18 hours. Then there is a risk of preterm labor, and if you see meconium stained fluid, or there is a GBS infection positivity, or due to any chance there is a long labor duration, if multiple pervaginal examinations have been done. So that's why in these cases, when there is rupture of membranes or the patient has presented with fever, or if you suspect chorioamnionitis, you have to minimize the number of pervaginal examinations. Clear? And one more risk factors. Now we'll see what are the complications you may get. Complications include, first we'll see the maternal complications. There can be bacteremia, and that can lead to sepsis, septic shock. There can be DIC, adult respiratory distress syndrome, and during labor there can be uterine atony that can result in postpartum hemorrhage. There can be pelvic abscess. Then there are chances of abruption of placenta, and also there are risk of thromboembolism, and in these cases if there is any wound infection can also occur, and there can be a need of cesarean section. Clear? Now we'll see the complications in the fetus. So for the fetus, there is a risk of preterm delivery, and there can be a low Apgar score. Okay, even it can be less than 3. Then even the neonate can go for sepsis. There can be pneumonia and meningitis. Cerebral palsy can also occur, and even death can be anticipated. Clear? Okay. Now we'll see what are the clinical features. Okay. Clinical features in chorioamnionitis include fever. There will be maternal tachycardia or fetal tachycardia. Then on examination there can be uterine tenderness. There will be foul smelling amniotic fluid, and there can be purulent discharge also. So how will be the presentation? Okay. So if you see the presentation, it can present as an case of isolated maternal fever with a temperature more than or equal to 39 degrees Celsius. Then there can be suspicion of infection if this maternal fever is associated with increased WBC count more than 15,000, or there is fetal tachycardia. So the normal range of fetal heartbeat is 110 to 160 beats per minute. So if it is more than 160 beats per minute, then you have to think about fetal tachycardia, or if there is a association of purulent discharge with fever. Clear? Confirmation of the infection can be done by doing amniotic fluid tests. So the amniotic fluid will show the presence of bacteria itself, or there can be leukocytes, increased level of leukocytes. Because of the presence of bacteria, you may get a positivity in the culture if you give for a culture. Then the glucose levels are reduced less than 15 milligram per deciliter, and you will have an elevated WBC count more than 30 cells per microliter. Clear? And other ways to confirm the infection include, histological examination of placenta, so how will you go for the treatment of chorioamnionitis? So treatment, you have to plan 3 things simultaneously. Number 1, you have to start broad spectrum antibiotics for the mother. You have to give antipyretics, and simultaneously you have to plan delivery. Okay. So what are the broad spectrum antibiotics you can give? You can give drugs like ampicillin 2 gram IV every 6 hours. Okay. Then you can consider giving gentamicin at a dose of 2 milligram per kilogram IV, that can be followed by 1.5 milligram per kilogram IV every 8th hourly. If you are planning delivery by cesarean section, then you can additionally add 1 dose of clindamycin at a dose of 900 milligram IV Q 8th hourly, or even metronidazole at a dose of 500 milligram IV Q 8th hourly. Okay. Suppose if there is any allergic to penicillin group of drugs, you can prefer giving clindamycin, or if there is clindamycin resistance, you have to go for vancomycin. So antipyretic, you can give acetaminophen, and delivery, there is no need for cesarean section. Mostly you can plan for normal vaginal delivery. If any obstetric complications are arising in between, you can plan for cesarean section. Clear? I hope you understood this topic. So with this, we are completing the discussion on premature rupture of membranes. So until we meet in the next video, happy learning, keep going and take care.